It is really my pleasure and honor to introduce our guest speaker, Dr. Peter Lawrence. Many of you know Dr. Lawrence, who is the Chief of Vascular Surgery at UCLA, and also the co-editor of our flagship journal, the Journal of Vascular Surgery. Dr. Lawrence has been a friend and a mentor for many, many years, and he has been a champion of vascular surgeons across the country, and has been the voice of reason. We're really thrilled to have him. Unfortunately, we had planned to have this in person, but the COVID situation in our state necessitated that we turn this into a virtual meeting. But hopefully Dr. Lawrence can come back when things are open in the future and participate in one of our meetings. So Dr. Lawrence, thank you so much for agreeing to do this, and we look forward to your talk.
Great. First of all, thank you both Ash and Peter for inviting me. Like you, I'm disappointed that I didn't get to visit with you in person, but this is a great alternative. So 2 caveats: I'm disappointed not to be there. Second of all, I had a little cold a couple of weeks ago and have a slight reactive airway. So I cough. Don't worry, I don't have COVID, and I feel well, and it may interrupt a couple of slides. I hope not. What I'd like to do is talk to you, and then we'll have an opportunity to open up for discussion and questions. But what I'd like to do is talk to you about a journey that I guess I personally have taken, but many of us have taken in the issues of quality related to vascular disease. And I'm going to focus today on PAD, primarily claudication, because that's what Peter Hankey asked me to focus more on, but a little bit on critical limb-threatening ischemia. And the summary of what I will say is that appropriateness is something that we haven't focused on in the past historically, but are beginning to understand it, and that good results are not enough. And I'd like to first recognize an old friend, Norm Hertzer. I think for me, one of the most influential presidential addresses was one that Norm gave in, I believe it was 1995, in which he talked about the Cleveland Vascular Society quality initiative, where every member contributed the data and the results from their procedures, and they benchmarked each other. So they had mortality outcomes from abdominal aortic aneurysm and stroke results. And Norm then took this on a national level, federally, and I think convinced an awful lot of people, including the Society for Vascular Surgery, that we needed to have databases, and they were critical for quality, for benchmarking, and I just added also to determine appropriate care. But they're the key to writing practice guidelines and the key to quality. And following Norm's address, many people had already been working on looking at quality and outcomes. But what we focused on primarily were truly on outcomes. We did not focus on appropriateness. I cared about what my stroke rate was, what my mortality was from open repair of an abdominal aortic aneurysm. And we really didn't spend a lot of time thinking about appropriateness, which is what I'll get to later on in my talk. Almost simultaneously, Jack Cronin went, and I know many of you know Jack, and I believe Jens was involved with the session today, Jens Jorgensen, but Jack then looked at another way to look at quality, which was the variation in healthcare throughout, and looked at vascular procedures. And I think showed some very interesting things, again, looking at quality and variation, but also began to look at appropriateness, because as you can see here, this is one of many pages in that book, but you could see that there were some places in the United States that did 3 times the frequency of procedures as other places in the United States based on Medicare data and Medicare patients. So the variation, not only in outcomes, but in appropriateness or the use of a procedure was great. Of course, that led to the Vascular Quality Initiative, which started with the Northern New England study group and a group, first of all, of cardiac surgeons, and then followed by that vascular surgeons who collaborated and shared information, benchmarked each other, and used it as a way to improve their quality. And I think all of you know the rest of the story with VQI. This is a little bit of an old slide as far as numbers. I think it's close to over 1 million patients, and this was a couple of years ago. But the whole idea of the VQI is that we enter a data that's systematically entered using definitions on common vascular diseases, and then benchmark looking at ourselves and trying to determine the outcome. Most of you also are very familiar with this because you're having a meeting today to discuss this, but that there are regional groups that get together a minimum of twice a year and discuss quality in their region. I'm part of the Southern California Voice Group, and we have a great attendance, and our meeting is coming up. Actually, we just had a recent meeting, but our next meeting is coming up in the not too distant future. Well, what we get out of that is we get benchmarking, and here it is by center, and you can see those that were above and below the expected outcome, the blue being the expected, and some that do much better and some that do much worse. And in this example of discharge from carotid endarterectomy, we look at how those who do better can teach those who aren't doing as well for quality improvement. So with all this good news about how we measure and how we study outcomes, and what is the problem? What is the elephant in the operating room? And to my opinion, it's the fact that we have not concentrated as much on the appropriateness of procedures, something that at least early in my career, either I didn't think about or I just assumed that we were all doing appropriate procedures. But in fact, and so if we look at it and think about it in terms of VQI and outcomes were the primary measure from VQI. So in that red bar in the center, to the right is what VQI focused on, but on the left is appropriateness. And I would define appropriateness is having the right doctor take the right patient and at the right time, do the right procedure in the right place. So it deals with the appropriate management of a patient. Everything to the right of the red bar is what we've traditionally measured in VQI, although now we're beginning to shift to looking at both, but is the outcome, what's your stroke rate, what's your mortality, what's your limb loss, your amputation, and those are different types of measures. Well, this is not a new concept, and when I was a medical student in Boston, Dr. Lucian Leap was a chief of pediatric surgery at one of the major Boston teaching hospitals. He was just a very, very well-respected person. And at sort of a late age, but before retirement, he got interested in what he called unnecessary surgery and had a faculty position at the Harvard School of Public Health. And any of you have read his works, he was really the pioneer in surgery and looking at appropriateness or what he called unnecessary surgery. And at the time that he wrote this, which is a number of years ago, Dr. Leap is no longer alive, but when he wrote this, he estimated that he thought maybe in surgery, not vascular, but all of surgery, approximately 30% of procedures were possibly inappropriate. So this was a very high level analysis and by somebody who influenced the Harvard School of Public Health to look into and think about this. But he wasn't, again, the only one thinking about it. In fact, that Journal of Excellence, the USA Today, but actually had a pretty good article that I read. It was published in 2013. And here you can see where two reporters looked into how often surgeons do or proceduralists do inappropriate or unnecessary procedures. And their estimate was, like in hysterectomy, based on practice guidelines, up to 70% of the hysterectomies done in America were what they would have considered unnecessary. Now, there would be some debate about that, but certainly it was a significant influence. In our own field of vascular disease management, what was pointed out in this article was they correlated the control or reduction in the number of coronary angioplasties with the increase in the number of peripheral angioplasties. And at least the claim made by them was that that physicians who could dilate and stent vessels just moved from one bed to another and started doing peripheral stents because of the federal government oversight over coronary angioplasties and coronary stents. Well, if we fast forward another couple of years, this is an article that when I was the president of the SBS, I was asked to comment on by the New York Times. They sent this to me and they said, we're going to be publishing an article about a physician. They didn't tell me the specialty at the time. It turned out to be a cardiologist, but a physician in Florida who, in their opinion, has been doing unnecessary procedures. And the way they came to that was because of the amount of billing. And as I remember it, it was like something like $18 million worth of Medicare bills in a single year. And when he was interviewed by them and they questioned him about the appropriateness, whether all these needed to be done, he said, I just don't understand what you're talking about. I have the lowest amputation rate in the entire country. And as I thought about that and was asked to give a response, I realized that essentially, if you should have the lowest amputation rate if you're doing unnecessary procedures, because you can't make, in other words, someone who doesn't need a procedure, hopefully you won't make them worse. So the low amputation rate was sort of a marker for the fact that he was doing unnecessary procedures. And in fact, when they looked at it in a little bit more detail, many of these were nursing home patients. They were in wheelchairs and they were having procedures with a diagnostic code of intermittent claudication. Obviously, it's pretty hard to have claudication when you're in a wheelchair. So I was asked to write this and sent this to the New York Times. It was published there, and just talk to them about how our profession, our society needed to think about appropriateness in the care, and that was one of our ethical responsibilities. What surprised me was that after I sent that in, and the SBS also circulated to our members, I got over 500 responses. And what I realized at the time was so many vascular surgeons have been observing this in their community, not necessarily all other specialties, but that they were seeing inappropriate or unnecessary procedures being done for vascular disease, and they really didn't know how to address it. So the response was, to me, overwhelming, and led partially to the presidential address that I gave called Better, and it hopefully is something that some of you at least have read. Well, in addition, we'll talk about a couple of other explanations, at least, that were used for why there was an increase. And this was a paper that came from Duke, from the Duke group that was looking at outcomes, and showed that there had been a dramatic increase in atherectomy, a 50-fold increase over 5 years. And they concluded that possibly, they didn't know for sure, but possibly said that some of these procedures were inappropriate or unnecessary. But also this paper that another group wrote, and Mike Conti was involved in developing this, and some of the rest of you may have been involved in it, showed that not only was it that the procedures were being increased with atherectomy, but that there was an increased number of patients with restenosis, and that actually the number of procedures that were done at the time of the writing of this paper, there were more procedures being done for restenosis than there were for the initial PAD, which for most of the patients was intermittent claudication. Most recently, Caitlin Hicks, whom I'm sure many of you have read her works. If you haven't, don't know her, but many of you probably know her. her work that was published in the JVS was actually picked up by the Wall Street Journal. And they looked at Medicare data and some of the outliers in vascular procedures and raised the question, as the Wall Street Journal did after that, about whether unnecessary or inappropriate procedures were being performed. And they also pointed out this wasn't unique to vascular surgery, but that there had been similar evidence in spine and coronary interventions. So as I got to thinking about this and was sort of responsible for a year or two in the SBS about thinking about this issue, I tried to decide, not assuming that every increase is bad, how can things increase so rapidly, whether it's after atherectomy or PAD or carotid procedures, whatever it is. And one of them is that we have more minimally invasive procedures and devices. And this may be good that patients who weren't treated before are now getting treated. Also, there are different patient populations. I know when I see patients now, I do more venous than arterial disease, but when I see patients with venous disease, they'll tell me that their mother or father had a procedure and was admitted to the hospital for a week, and they've never had their venous disease taken care of because they had no interest in a week in the hospital. And that's the way it was 50 years ago. Today, with minimally invasive procedures, it's opened up procedures to many more patients who have the same disease. And then I think we all know that different specialties have access to different groups of patients. So it's not only vascular surgery, but interventional radiology. It's a combination of multiple specialties that are now taking care of PAD patients. And the other thing which has been blamed by many people is the site of service. For all full disclosure, we have an office-based lab, or what we call ambulatory procedure unit, in our division. We find it to be extremely valuable to deliver care to our patients, but it does have the potential, unless it's matched, and I know you discussed this today, and Krishna Jain talked about how you have a quality program and assess quality in an office-based environment. But there is the potential for abuse or inappropriate procedures. One of the other major explanations for the dramatic increase in cases, here you can see the Medicare payment changes in different procedures and different CPT codes, and how much of a difference it is between an office-based OBL versus a hospital-based is the physician reimbursement, which is the physician on the right and the facility on the left. And in some situations, there's a dramatic difference, which is of great benefit if you can control expenses within your ambulatory procedure unit or OBL. Well, just so that we don't get too hard on our physicians and our colleagues, at the time that I gave my talk to the SBS, I looked into the pay of hospital CEOs and how their compensation was structured. And it became very evident to me that CEOs have an equal potential for conflict because their pay was dependent to a large extent on profitability of the hospital, and profitability of the hospital often was related to the number of operations, the number of procedures. So the more procedures, the more RVUs, the more CPTs, however you measure it, that had a major impact. And some of the CEOs of for-profit, but also not-for-profit hospitals were listed among the highest compensated CEOs in America. So there's a lot of, it's a lot more than just physicians. The other thing I did want to point out is there's a potential not only for overuse or inappropriate care that's too much, but also underuse. And this is just one of many examples of patients. This was published in Lancet a few years ago, where there's a failure to deliver a health service that leads to worse quality. So it can go both ways. And what this tells me is that appropriateness is the key. Doing procedures that are indicated, not doing too many, also not doing too few. So I just thought I'd put here that this is not a simple issue, and it cannot rest by critiquing or criticizing one group of physicians or a particular site of service. There are so many factors that enter into appropriateness. Do people have the training and knowledge, even know what's appropriate? Where is the site of service? There are potential conflicts no matter where it's held. The devices that we have are sometimes the data surrounding them may be either biased, or it may not truly reflect what will happen in the real world. And the three that I'd like to talk about now, in addition to reimbursement, are the three things that I think are most important when we talk about how to improve quality. And that is having reporting standards, developing practice guidelines, and what I heard some of which was talked about at your last session, which is appropriate use criteria, and the fact that there now is one appropriate use criteria that has been completed for intermittent claudication, and as you heard from Nick, that will soon be published in the JBS. And I've fortunately had the opportunity to review that and seen what that is. So we start with reporting standards, and essentially what this is definitions. We want to be able to compare in the literature apples to apples. So if we have a paper on PAD and amputations, the question is, in amputations, are you talking about below the ankle, toe, and forefoot, or are you talking about above the ankle? If you just lump them all together, you can get a misrepresentation of the literature. If you talk about a stroke post-op, what's your definition? Who developed or who made the diagnosis? If you talk about restenosis, are you talking about degrees of stenosis, or you're talking about those that require reintervention? So reporting standards are absolutely crucial. Many of you know that they're published in the Journal of Vascular Surgery and on the SPS website. And some of them are actually published within the study, like in a systematic review or in practice guidelines. So moving from the reporting standards, we're essentially a dictionary or definition dictionary. The next thing to level up is what is by the Institute of Medicine defined as clinical practice guidelines. And those are systematically developed statements to assist the practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. And they are different from appropriateness. And I hope that by the end of this, that you will not only understand, but believe that they each have a role. Of course, they have to be free from conflict of interest, who the writing team is. They have to be developed based on a systematic review, and they also have to be based on specific questions called Pico Questions. And Pico Questions it's a shortened version for patient, but essentially what it is that you get the opportunity to raise 3 to 5 questions. So you don't have the opportunity with a practice guideline to have 100 or 200 scenarios. A diabetic who's a smoker with intermittent claudication and is able to walk 7 blocks versus a non-diabetic. In Pico, you have 3 to 5 questions, which are then addressed by a literature review. And then the key to practice guidelines is that the writing group, whoops, I lost that. Let's see if the writing group, the key to practice guidelines is that the writing group has to come to consensus, and they give a recommendation based on the strength of the data and the quality of the evidence. So you've seen 1A, 2B, 2C, and obviously we'd like everything to be 1A in vascular, but much of ours is 2B or C. This is then written up in what's called PRISMA guidelines. So practice guidelines are very important, but they are limited in that you can't look at every single clinical scenario. And that is one of the factors, I think, that makes them different, and the major factor from appropriate use criteria. Well, this is just an example in patients with intermittent claudication, and I think most of you are probably familiar with, Mike Conti and Frank Pompicelli, who were leaders in writing the practice guidelines in PAD for claudication. One of the things as you read through this abstract is that they define and believe that the minimum threshold for recommending a procedure should be that there's a greater than 50% likelihood of a sustained success at 2 years. Their sense from writing this when they developed the criteria was very few people would have a procedure that had a less than 50% chance of success at less than 2 years. And so that became one of the definitions, which was then used in the appropriate use criteria, which we just completed. But practice guidelines are important. I think many of us use these as having advice, and it's based on a critical review of the literature. These are just a few of the practice guidelines that the SVS has been involved with. Some of you may know that it's not only arterial disease, such as what I just showed you, the asymptomatic claudication. The global guidelines are for critical limb-threatening ischemia, and we're an international initiative. Actually, Dr. Glavitsky and I, when we were involved with the SVS, went to Europe and convinced the World Vascular Federation to initiate that, and that's why it's a collaboration of vascular surgeons throughout the world. And then you may also realize that it's not limited just to vascular disease, that Tom O'Donnell was the lead author on a practice guidelines in venous ulcers. There are some challenges with practice guidelines, and one of them is that two groups can look at the same data and come to different conclusions. And this is an example where the SVS, practice guidelines in claudication, and the SCI, the Society for Cardiovascular Angiography and Intervention, came to different conclusions. One is that the PAD and claudication below the knee should not be treated and should not have an intervention, whereas SCI came up with the fact that it was appropriate when there was limited disease in the infrapopliteal. So one of the challenges is that sometimes practice guidelines are different. I know if you ever heard Ann Abbott's talk, but for carotid practice guidelines, her claim is that there are 32 practice guidelines in the world, and that many of them don't agree on the approach. They're all come to different conclusions based on the same data. Well, lastly, I want to move to appropriateness, because that is what I was asked to talk about, and that's what's evolved as a very important part of quality. And this is the RAND definition of appropriateness. And it is an expected benefit where the procedure or health benefit exceeds the negative consequences, and by enough of a margin that this procedure is worth doing. So that's really the technical definition of it. I just want to point out that appropriateness and AUCs are not new. In fact, radiology has written a huge number of appropriateness criteria, and they started doing this, as I was told, because they were asked with children who had head injuries and were all getting CT scans when they went to the emergency room. And I believe it was CMS that asked them to develop appropriateness guidelines. When should you get imaging of the head for a child that hits their head and loses consciousness? What are the criteria? But they've expanded that, and they have a very large appropriateness format and a large number of studies that have been completed. The American Hospital Association, I'm not going to go into each of these, but they were asked as to when people should be transfused, and they came up with appropriateness for that, for antibiotics. And then the American Heart has had a number of appropriateness guidelines, particularly related to coronary disease, myocardial infarctions, and when you should do a catheterization. The methodology for appropriateness guidelines is one that has been standardized. When I started this, I didn't even know that UCLA, the RAND Corporation is in Santa Monica, and I certainly knew that, but I didn't know that they had appropriateness methodology until a few years ago. And as some of you know, Karen Wu, who's in our division, has been great at working with RAND and working using the RAND system, and has taught many vascular surgeons about it. And essentially what the RAND system is that, first of all, there's a review of the literature, just like for systematic, just like for practice guidelines. And that's given to a group of experts. And then those experts are presented with a variety of scenarios, and it can be 500, 1,000. It's really extensive, the number of possibilities of options. And they're asked to say, is this appropriate, possibly appropriate, indeterminate, or is this definitely, so is it appropriate, uncertain, or inappropriate? And each person who's on this group goes through and grades every clinical scenario. And as I say, there can be hundreds of them. And then they come back for a second round. It's the iterative process, and they discuss it as a group, and they come to conclusions. Well, the SVS claudication AUC, as you heard, I think I heard on the discussion from Nick, you have a number of people from your Michigan Vascular Society that participated. Karen Wu led the process, but it has now been completed. They use the RAND method. It's called RAM, or RAND Appropriateness Methodology. And the content experts are the people that you see here, and went through a large number of options. The literature review that they did was actually done by the Mayo Clinic, which is often connected to the SVS literature reviews. And they had several questions that they asked them to look into, which became the basis for the review. What they concluded was that there wasn't a lot of high quality evidence, and that's a perfect time for an appropriate use when there isn't clear-cut prospective randomized data. And they did a summary of the literature, which was then available to all of the panelists. As I said, we talked about reporting standards, and it's critical that there be definitions of what it means. Is nicotine use mean, you know, how many cigarettes, how often, how many years? Antiplatelet the same way, which ones? So the definition. And then for each clinical scenario, you got an option of putting anywhere between 1 and 9. Did you think it was inappropriate, appropriate, indeterminate? And you get to have this like a Likert scale. And this became the basis when you put it all together. This becomes the basis for the tables that I'll show you in a minute. And then you put all of them together and then categorize them as inappropriate, indeterminate, or appropriate. And this is just an example. I don't want to show you the data from the paper because it still is going through a public review process. The doc committee has received it, and I've actually read it and written the editorial, and Dr. Peter Glavitsky, who's a co-author, the two of us will be submitting that pretty long editorial about the importance of appropriate use. But this is just an example of aortoiliac disease with a number of different factors, whether you use nicotine, what the overall health and frailty is, and then how the aortoiliac, is it complex, is it straightforward? And as you can see here, you have the different categories: A for appropriate, I for inappropriate, and the yellow is for indeterminate. Once you get the completion of that, the AUC, as you do with the practice guidelines, you need a journal that you trust to publish it. And we've made a real effort to publish reporting standards, systematic reviews, practice guidelines, and appropriate use criteria, and to ask the authors to really adhere to the principles that are outlined, such as the PRISMA guidelines for publication. So these are considered and will be high quality, highly referenced papers. Now, what are the next steps with appropriate use? Well, now there has to be a validation, and that's a retrospective one where you apply it to existing data, a prospective step where you look at randomized between best clinical judgment versus the criteria. And then one of the hardest things to do is to constantly update these, because procedures change, technology changes, techniques change. so they don't last forever. Well, getting back to the to VQI, so I think that and what we have appealed to Jens and VQI is that we need not only a COPE report, which is on outcomes, your stroke rate, benchmarking, the others, but CAPI. How many of these are appropriate procedures that you've been doing in a different category? And I just threw in UCLA. This is not real numbers, but UCLA, if you were to do 119 procedures, and this was for claudication, and at UCLA, hopefully this is not the case. You got no post-exercise ankle pressure. So your diagnosis of claudication was not a physiologic diagnosis. Only 49% of patients were advised to exercise or put in a supervised exercise program. And you didn't tell patients who have claudication that the likelihood of an amputation is extremely low. And one of the biggest challenges is that some who do inappropriate procedures have patients fearful that they're going to have an amputation when in fact it's just the opposite. So those would be 3 examples of things that you would get in what I'm hoping the VQI will give to all of us, which is not only a COPE report, how you did with the procedure, but the CAPI, how appropriate your procedures were. There have been a lot of other proposed changes. One of the things we have to realize is appropriateness is not going to go away. And some of the vascular surgeons who have pleaded to not publish appropriateness criteria need to realize that if we don't publish it as a specialty, another specialty or less experienced people are going to publish appropriateness, and we'll be stuck using their AUCs. And I think that there have been several options. One of them that's been proposed, and you'll see the Medicare website, is that for people who overuse procedures by a large amount, that the reimbursement may be changed based on the appropriate use criteria, and that you would link the procedures. And the other one is that for durability, that you don't pay all the money up front for procedures that may not be durable procedures. So you meet with a Conti of, do you have more than 50% of your patients have a benefit at 2 years before you pay the full price. This is, in an OBL, there's been some real concern. And as you probably know, Kim Hodgson is heading up a group, and they've already done, some of you may have already participated in the beta test on certifying OBLs so that they are for sure, and maybe Dr. Jane can comment on that. I imagine he's been involved in the facility accreditation, but there are a number of factors, we have in ours, we have AAAHC, we've got a vascular lab that's accredited. And I think that we believe at least that and we use VQI for our data that's collected in our OBL. As I say, this is not something that's going to go away. And this is actually, for those of you who haven't seen it, this is the CMS website. They've extended the operation and testing period, but their goal will be to link appropriate use with reimbursement in some way. And they've extended it to 2022 to January, and it may actually go farther than that. And this, so you can see, this is not necessarily for vascular disease, but a number of other areas. So CMS is, from what I can tell, is going to use appropriate use as part of their criteria. Now, one of the things that's always brought up, I don't know if Bill Brown is on the session, but I remember talking to him a few years ago about what the legal implications are. And he pointed out that they're often, the guidelines and appropriate use are often used in malpractice cases, but they're the best for the physician when they're evidence-based, that if they are based on a review of the literature and evidence, and when multiple societies participate. And that's not the only, but it's sort of one of many reasons why societies get together. And then what he pointed out is the disclaimer is important. These are guidelines, the criteria, they are not requirements, and individual judgment is appropriate in delivering care. It's only when someone repeatedly does something that is inappropriate that this should kick in and raise some red flags. So I'm going to conclude by saying that I would argue that, at least for me, and hopefully for many of you, we've learned that just reporting great outcomes is not enough. What Norm Mercer said a number of years ago, 30 years ago, outcomes are crucial and we all need to know our outcomes. But it's not enough, particularly in patients with PAD. And I would argue that the other side of the coin is equally important: appropriateness of care. Make sure that you're doing your procedures on the right patient, done by the right physician, the right procedure is done at the right time in the right place, and that you have great follow-up, the correct follow-up. And that's what really results in appropriate vascular care. So with that, I will conclude. I think we're about 40 minutes into my talk, and hopefully you enjoyed it. I certainly enjoyed seeing those of you who I could see on the Zoom, and I'd be happy to answer any questions.
Dr. Lawrence, this is really a fantastic talk. And when you brought up that slide about CMS looking at appropriateness, it reminds me of the situation where if physicians aren't able to manage themselves and control themselves and police themselves, somebody inevitably from the outside is going to come in and police them, and that would be terrible. And a little bit earlier, I was mentioning that all of us now have to go through calling an 800 number to get your patients approved for a CT scan or an MRI, and speaking to a retired physician who doesn't understand anything about the specialty and who has the power of saying yes or no to authorize the study. And I'm afraid that if we don't do something about this, it'll come a day when a vascular surgeon won't be able to do a procedure and has to call an 800 number to get approval. What are your thoughts on that?
Well, I definitely agree with you. And I think that sometimes as a specialty, because we're small, we're concerned that we're going to be subsumed by other specialties. But when you think about what specialty is in the best position with AUCs, and if you look at, when you see the tables on AUCs, sometimes endovascular is appropriate, sometimes open is appropriate, sometimes it's a dealer's choice. We do everything. We do vascular medicine, we do vascular surgery, we do endovascular procedures. So I think the threat is not as much to vascular surgeons as it is to other specialties where, you know, the old expression, if your only tool's the hammer, you begin to treat everything like a nail. And I think that that applies here, and that we are going to be in a good position. And the other point I'd make is that we've learned from Medicare that to a large degree, it's a zero-sum game. And there are many, many patients out there that have legitimate vascular problems. So we need to have our outpatient centers available to see a number of patients. But if we do that, there are plenty of patients for us to take care of, which we're not going to run out of patients. So I would much rather take care of people that need care than patients who don't need care. And I also think that our specialty is the right specialty for PAD. There's nobody like us, and that's what makes us unique.
Agreed. Peter Henke, do you have something to say?
Yeah, thanks again, Peter. Great talk. And again, appreciate you joining us from California. Really continues to be such a timely topic. I would say, or I'd get your opinion in it. It's a little bit what Ash asked as well, but unless there's financial de-incentives for overuse of procedures, how do you curtail that? You can have all the evidence and practice guidelines, you know, but many of those centers are not on this call or don't participate in registries, may not care to be accredited, even if that makes a difference. So how do you put the financial teeth behind this?
Well, as some of you may know, I represented the SVS a number of years ago in MedCAC, and there were two MedCACs that were on vascular when I was on it over 6 years, one on arterial and one on venous disease. And one of the surprising things to me was I would say to the people who were in CMS, there's an awful lot of people doing procedures that have had no training. And why is it that you don't have different reimbursement or no reimbursement unless you've had formal training and done a residency or fellowship? And as you know, there are a lot of not only venous but arterial procedures done by people with essentially no or inadequate training. And what they told us was that they were instructed by Congress, once you get an MD degree, that as long as it's up to hospitals to provide privileges. And I said, but that doesn't recognize the reality, which is OBLs can do procedures and do them outside of the hospital. Who's going to control that? Just what you're asking me. And so I think one of the most important things is to push for the fact that certain and many procedures should only be done and only approved by the specialty or reimbursed when you've had specialty training. So to me, learning that on MedCAC, that is one of the most important factors. There are a number of others, but I think that you can't have people doing procedures who have had no training or very little training. First of all, they overuse, and we've seen this on the venous side where these venous factories that just crank through patients, and often they don't have any reflux and they're getting their veins ablated. So we need to have appropriateness, and it needs to extend into the office-based environment, both having to have a quality program there and also having to have physicians that are trained to do the procedures that they're getting reimbursed for. And that's going to be to me, one of the most critical factors. And that's a lobbying effort.
Yeah, great.
Hey, Peter, this is Rob Bollner, Michigan Vascular in Michigan.
Hey,
really enjoyed the talk, and I think it's just very appropriate that we're discussing this at this time, because there's been a lot of rancor going on within a lot of different communities. But I think ultimately, if we look at what we need to do, we need to drive quality. We need to define quality. And I think the SVS is in the perfect position to do that. I know the certification process and the verification process is somewhat cumbersome, but I really believe that if we can get that going and have the VQI associated with that, with long-term follow-up, I think we really have a path forward such that maybe payers will recognize that and say, well, if you're certified, you don't need pre-authorization. Or if you're certified and verified, you're a tier 1 provider, and steer towards the quality programs. I don't know if we can get there, but I think that's what it's going to take.
Absolutely. What you said is critical. And, we all should be aiming toward the highest quality care, like what we would want to be taken care of if we were a patient. But I think that your principles are right on, spot on. And one of the things that any of you have heard our presentations about the journal, is, there's a pyramid of quality of evidence, but there's also a pyramid that deals with the best care for our patients. And we make a real effort to publish and to edit and to have editorials on papers that deal with appropriateness, practice guidelines, reporting standards, systematic reviews. And I think that that's really a key. We need a society that's committed to it, and we need to have this published in high quality academic journals, and then we have to have it distributed to the community. And that includes patients, primary care physicians, other specialties, as well as vascular surgeons. If we just all read these papers, as you said, and the people who are also delivering care don't even belong to our society and don't read this, then we're talking to a very small audience. So the key to distribution of this information for both systematic reviews, practice guidelines, and appropriate use criteria is absolutely critical.
Yeah, if I can make a comment, Peter, excellent talk. Thank you very much for doing it.
Sure.
And one of the threats that we have not talked about at all, the biggest threat right now is private equity money. There are MSOs being created, which are somewhat unethical, sometimes illegal. And actually, I know for a fact that SV has been approached for at least one particular company that is running in USA with multiple centers doing extremely bad things. Various states have gone after them, but the society's hands are tied in terms of dealing with these people, because the legal system stops the society from acting on behalf of patients because of the legalities. So there's a lot of private equity money going into the OBLs and the ASCs and everything else. And that is one area where if we don't concentrate, it'll become a cancer.
It is so disturbing what you said. I know what you say is true. I'll tell you, on the 405 in California, if any have been here, it's a huge, big, 6 lanes each way. And there's this huge advertisement for a group that do both arterial and they started with gastric bypasses, and now they do a lot of venous work. And I called them up and I said, I'm interested in getting my veins taken care of, but I was curious about the doctors to make sure that they were really experienced. Oh, of course, they're very experienced. I said, do you have the specialties of the people that are doing this? And this is a big company and they have sites all over Southern and Northern California. And she said, well, I'll have to go and check. And so I said, well, I'll wait on the phone. You just let me know. And as I remember, the one was a neurologist. I looked up his name and he basically was doing EMGs before this. One was an emergency room doc. I can't remember all of the specialties, but they're people who have had no training and that gravitate to these for-profit centers. So part of it is, as I say, if you could limit the specialties that were allowed to do this, that will be one step. But the other is, I guess, if something gets to be so highly profitable, there's going to be someone that's going to try to put together a group to take advantage of that. Do you have any solutions, Krishna, for what you do when a big company comes into town? And
well, one of the things that happens is that it takes about 6 months when they have a lot of bad results and they start coming to the ER. And when the vascular surgeons are taking care of them, and then the vascular surgeons go to the board, to the state board, complaining about it. Then the state board after that approaches the society, whether it be SIR or SVS or ACC, is for guidance. And that is the point where we are stuck because we are not able to act aggressively enough to advise this to the medical boards in the states what to do, because we just get stuck there. And that's why these bad characters continue to do the cases. I know several people doing that, unfortunately, but I think societies need to have more power, legal power, to be able to advise the state boards how to act.
Well, Bill Brown I'm not sure if he's on the call, but that was one of the reasons why I contacted him, because I knew that, not just for this talk, but just in general, because I knew that the legal barriers to prosecuting, and I've had a couple of former trainees in our program who've gone into practice and had a legal challenge with quality with either one of their own people who was not up to snuff or someone in the community. And it is a daunting process and it's very expensive. And for a lot of people, it's just not worth the battle. But I'd be interested, I don't know if Bill is on tonight, but it would be great to hear his advice as to what should be done.
I don't see him, but Craig Brown has his hand up, wants to ask a question.
Okay, hi, Craig.
Yeah, hey, Dr. Lawrence. First off, thanks for a great talk. It's kind of near and dear to my heart, so I appreciate you coming and talking with us. My question was about, there was a paper that came out this month in Health Affairs by Cerullo et al. That basically showed that private equity acquired hospitals increase their, they sort of increase the use of profitable service lines. And that's not surprising to anybody, I don't think, but it drives home the point that you made earlier, which is that maybe physicians in particular, those who work at these hospitals that are private equity acquired, are going to face pressures that are maybe more indirect than we've seen in terms of the hospital system sort of pushing providers to do these maybe inappropriate operations or procedures. And so I'm wondering, is there any path for the SVS to be involved in that? And how can we combat that when it's maybe not the physicians who are directly involved, making choices about inappropriate care, but maybe these kind of secondary resources that get allocated towards particular service lines?
Well, I've got to say that my role and my leadership role in the SVS ended about 5 years ago. So I can't tell you what SVS is doing, but I do think it's a critical question. And we have seen an increase in the number of physicians whose practices are purchased and you work for the hospital. And I think what you not only implied, but I think said very directly is that when somebody is your boss and that you are working at will, that you are at risk if you do what's right. That I mean, it's sort of the reason that in universities tenure was developed for universities. And unfortunately, sometimes tenure has gotten out of hand in protecting professors too much. But the reason it originated was because you're vulnerable once you're an employee of a hospital. And we have had that happen in California. And I've read a number of articles about someone who began buying up hospitals, and he made a fortune. He did exactly what you said. He just either closed services that weren't profitable or raised the price to at just an outrageous price. But patients and health plans, insurance companies didn't have any alternative, because if you're in a more rural area, it's either that hospital or nothing. So as soon as you go from being a community resource and a county resource to being a for-profit, you can be very ethical, but you have the potential to not be. So I'm not sure I have any solution, but I certainly share your concern that the more physicians that are independent of hospitals, and that will probably reduce this risk of immense pressure, which occurs when you're an employee.
This is
like somebody said, they said, follow the money.
Yep.
So
yeah.
Rob, you had something?
I did. I just wanted to mention, because again, this whole thing about the private equity is a real deal. I mean, I've been approached by private equity groups that would want to buy our practice. And there's a huge payout. I mean, so, I put a number of years into the practice, and, if you look at, if I retired, what I would get versus what, I would get with a buyout, there's a big incentive, big cash incentive for that buyout, but then you lose your ability to be who you are. And so, obviously our group has said, no, we're not interested in that, even though the principal owners and the partners of the group would do very well financially to do that. But what's going to happen. They're going to drive procedures. They're going to drive to do what is inappropriate. So I just say that that's one aspect. The other thing that I'm a big advocate for certification. And I think, again, we have to incentivize somehow a certification process where we value quality, outcomes, and value-based care. And, short of that, it's very difficult for the small group, the small private practice group, to participate in that process, because it takes time, money, and effort. And unless you incentivize that somehow or reward that in some way, it's going to be very difficult to move in that direction. So I'd like to know if Dr. Lawrence has any ideas regarding that, but how can we promote, incentivize participation in the registry, participation in, being certified, really, I think has to be monetized in some way from payers. But I think that's the only way we can ensure quality going forward.
Well, I don't have any easy answers. In fact, I'm in some ways a victim. Our division that's certainly works within a university environment, but when we initiated VQI, the hospital said to me, listen, we already have NSQIP if you want VQI, you'll have to pay for it. And I said, but and I know there are pluses and minuses to each, but I said, we really would like to be part of VQI. And so we self-tax ourselves $150,000 a year to enter data into VQI because we're committed to it. But what you brought up is exactly, if you're in a small practice, you can't afford to put 150,000 into it. We have a large practice and a large group. So we just make that part of our overhead. But I am very sympathetic to small practices. And I know of any of you who have trained with Michelle, with Mike Macaroon, but I guess at Pittsburgh, they have multiple hospitals, and if each one of them has to participate in VQI, that can also be expensive. So I think VQI needs to be responsive to what you're saying, which is this is a focus on quality, and every single person, we need to enable everybody to participate. But it's not an easy solution because data entry, to have the people paid to do not just the clinical data, but the demographic and other, it becomes very, very expensive. And if you're not part of an institution, I think it's tough to afford it.
And I'm sorry, I don't want to, take a lot more time, but I think the more we can get people participating in the VQI, especially the private practice OBL community, that's where we have a dearth of information and research. So I think there's 5 OBLs that participate in the VQI currently, outpatient OBLs. We'd love to have more data. We'd love to do the research on the outcomes in these OBLs, but with long-term follow-up and that long-term data, unless we get more people to participate, it's really difficult to say, okay, are we doing things appropriately? What's our outcomes long-term?
And I can tell you that when we review papers for the Journal of Vascular Surgery, either JVS or JVS-VL, one of the things that's always brought up by the reviewers is, does this include the OBLs? Because so many things can be done and be done really well with, as I said, our patients love it. But if they don't participate in data entry, it's almost hard to write a good paper on PAD and claudication if a third of the patients are being done in an office and they're not part of the database. It becomes it really limits the quality of the data. So figuring out a way to get OBLs involved is critical.